Welcome everyone to another episode and happy fall. Another episode of A Dose of Dizzy. And happy fall to all the students and all the professors out there that are going back and starting their fall semesters at the universities or wherever you are. This is actually a very special episode for me personally. The person that we're going to introduce has been one of the most influential people in my life. And, I have the honor and privilege of introducing Dr. Erin Piker, professor at James Madison University. And that's where actually I did my PhD program. So Dr. Piker was my PhD advisor and continues to not only have an influence on me, but, it continues to be an expert and leader in this field. So thank you so much, Erin, for your availability and, willingness to be on our podcast, our small, podcast here. So thank you.
Sure. Yeah, I shared this with you earlier. I don't listen to podcasts, but if Daniel asks me to do something, I'm always happy to work with him. And here we go. Yeah, it's so nice to have you on. And this season, we've been trying to get the experts of the field, and you are definitely top of our list. So I'm so glad it worked out for everybody. But it's been really cool. We've learned a lot about people's motivations to get, especially into vestibular research. So I'd love to know a little bit of your background and what got you into the field of vestibular and kept you there. Yeah. So, my background into audiology is not a straight path. I was not a CSD major. I hadn't heard of CSD. I hadn't heard of audiology. I was neuropsych and linguistics. And so my plan was to go into neuroscience and study language in the brain. That's what I thought I was going to do. And I was set to go into a grad program, and I was meeting with my advisor. I don't know if I've ever shared this with you, Daniel. And I was talking with her, and then I was touring all of these labs. And my gut instinct just said, you don't belong here. This isn't right. And I was honestly kind of bored, which is a shame. I'm looking at all these amazing things I'll get to do in these amazing labs. And I just thought, this is not what I need to do. So I took a year off. And some of my friends in linguistics were going into speech, and they were like, try speech. And so I shadowed an SLP, and I immediately knew, no, that was not it. And then they suggested, go shadow an audiologist. That might be more your speed. And the first audiologist I shadowed was in Virginia Beach, and they're doing vestibular assessments. They're doing a VNG. And I don't know if it was just the excitement of watching this thing. I had never seen it before. We were in this dark room. I will also say we were on the coast. It was late summer. There was a hurricane brewing, and there was just an air of excitement anyway, and everyone's talking about it. But I left there feeling excited and thinking, okay, audiology, that's what I'm going to do. Now at this point, this is all I know of audiology is I know VNG. That didn't stop me though. I applied to grad school. I started at Vanderbilt, and I hated it. I did not like audiology. My first semester, I thought I'm going to drop out. That's it. This is not the field for me. I was randomly assigned an advisor, and that was Gary Jacobson. Just arbitrary. He's who I was assigned to. So I set up a meeting with this person I don't know to tell them, I'm sorry, but I'm going to drop out. And the rest of the story is much shorter, as you can probably imagine. So I go to meet with him, and he's basically like, this is not all audiology. Let me show you what I do. Let me show you this side of audiology. And I was hooked. That was it. I was excited. He was passionate about it. He got me excited about it. I spent the rest of my AuD trying to do all the vestibular things I could do. If there was a paper, it was going to be a vestibular paper. If it was a presentation, I was going to make it vestibular. And sometime during my third year, I think it really set with me that I wasn't going to learn everything I wanted to know. My curiosity just kept going forward, and that I was going to need to go further. And so the PhD was a straightforward decision to see, not even learn research, which is what you do with a PhD. I just wanted to learn about the vestibular system. I wanted a way to keep going on that track. So I stayed and did a PhD with Gary for the next 4 years after that. And I've never been bored in my career. It's I often tell students my fear during my PhD was that I would run out of ideas. Like, how would I know what studies to do? And it is the exact opposite of that. I have too many thoughts and too many ideas, and it's about like clearing the space and focusing on one or two things at a time.
Yeah, I mean, talk about the butterfly effect. I mean, going and doing this, observation on the East Coast. If it hadn't been a VNG that day, or if you hadn't been randomly assigned to Dr. Jacobson, I mean, all of these little things kind of come into play, and and here we are. So it's just crazy how these things work out.
It really is crazy. Nothing was planned. It was almost like little serendipitous moments that happened along the way. I don't know where my life would have gone. I am not as organized and planned as my students are now. Like, I am amazed at how together their lives are in their 20s. And mine was a lot of just flowing through the air and seeing where I land. And I landed in Gary's office. And really, he was influential to me and steering the direction I was going to go. But I definitely knew vestibular was my interest early on.
So I feel like I'm always intrigued by individuals that don't come from a CSD background, because many students who enter audiology, including myself, that's where we came through. So what do you feel like, or now like looking back on coming from maybe a non-traditional background, how do you think that benefited you, or did it cause you to look at things differently as you were going through grad school or even now?
So early on, it was detrimental. My first semester, I was behind. I mean, everyone knew how to do audiograms. I was struggling with peer testing because I thought, what are you doing? Where are X's and O's? So early on, it was tough not having that background. I think as far as the, extent of my career, it's been a huge advantage. A lot of the vestibular work I do, I come from thinking, what do we do in visual neuroscience? And what do we know about the visual system that we don't know about the auditory system, that we definitely don't know about the vestibular system? And having a more science-based background has been really helpful in that regard. Reading through the literature outside of audiology, which is really important for a lot of the research I do to go beyond the ear. So it's helpful to have a background that also goes beyond that. I think the hard part is trying to find this field if you're not CSD. I mean, I just happen to also, my degree in linguistics is not a degree I use often. Most people are surprised they know I studied linguistics. I have no knack for languages or anything. But through that is where I met people who were going into speech. And it was through the speech pathologist who, as lovely as she was, I didn't like her job. But through her is how I found out about audiology. And so it's nice to have broad backgrounds coming in. I just don't know how people would find our field.
Yeah, I find that so interesting too. Like, that's why I loved hearing your story, because I know Daniel and I were both involved with Student Academy national leadership, and it's a big push of how do we diversify our fields, because I think it makes our research stronger. And I always am very intrigued by researchers that have different backgrounds, because I just think you approach the research so much differently. Even if you don't notice all these big changes, I think that background plays in really strongly. So I was just curious. I think that's fascinating.
Yeah, absolutely. So, I mean, to sort of kind of pivot from this point, you've done so much research in our field, and you've been influential, especially in the VEMP world. And, a lot of what we know about VEMPs comes from your research that you've done. But, do you mind talking a little bit about, what are some of your current interests? What are some of the research projects or directions that you are currently involved in?
Yeah. So there's still VEMPs. I can't escape the VEMPs. VEMPs are always there. I think I told you this, Daniel. After my dissertation, I swore I would never do VEMP study again. And what that was 12, 13 years ago. I'm still doing VEMP study. So I can talk about that, but I'll talk about some other areas I'm working on now. So kind of a major area I'm looking at is perception, motion perception. And then a new area that I've just started getting into is more sort of the patient experience, and also the educational part. How do we train vestibular audiologists, and not just train them how to technically do the things, but to develop things like cognitive empathy, effective empathy, and understanding for these patients? Because I feel like our patients are so important, and they're so special, and they come to us with a lot of needs. And oftentimes, after seeing multiple people, and a vestibular disorder is scary, and there's a lot of information online, and a lot of it's confusing. And so I take that role very seriously in training students how to work with our patients beyond just understanding the tests you're doing, but the effect it has. So that's a whole other area. But I'll go back to psychophysics, which Daniel started with me on a few years ago. And I'm going to tie that into a larger study I'm doing now. So I've got a 5-year study I'm working with Crystal Riska on at Duke University, where her main area is looking at the association between hearing loss and falls, which is well established. It's not really something that's debated anymore. We know if you have hearing loss, you're at a risk for falls, and that there's a dose dependence with that. What she's more interested in is what's causing this connection. What are the underlying mechanisms that are connecting the two? Is it really a vestibular issue, an undiagnosed vestibular issue, or is it vestibular plus? And I guess I could say, is it non-vestibular, but I don't think it is. I feel like if you've got hearing loss, you probably have some age-related vestibular loss that's causing some of the physical balance issues in that. And so in working with her, she had come to me and said, you know what, I really want a perception piece. I don't want to just look at vestibular reflexes. I want to look at a bigger picture. Can we work together on this? So I wrote that portion of her grant, and we'll be collecting data together. And so what I'm looking at specifically is how do we scale our perception of motion? If I increase the velocity, do you sense that increase at the same rate that I increased it? Is it a 1-to-1 relationship, or is it different? So we use a technique called magnitude estimates for that. And I use a rotary chair, and I use the yaw axis. So it's nothing that's so complicated it couldn't be implemented clinically at some point. It's pretty quick to do. And basically what we're finding is that there is a relationship between the stimulus and your perception of the stimulus. Obviously there is. In the lower frequencies where the vestibular system's not as sensitive, it's quite linear. So it's more of a 1-to-1. If I increase the velocity this much, you felt the increase was that much. As we go up in frequency, we lose that. We go to more of a nonlinear function, and it's actually compressive. So as I increase the velocity, your sense of motion doesn't increase quite as much. It gets further and further compressed as we go into areas where the vestibular system is more sensitive. And I think that alone is a fascinating finding, and I would expect to have nonlinearity in our system, as most sensory systems are. And this is young, healthy people, and this is how they're perceiving this. So we're extending that to look at age. We're extending it to look at fallers versus non-fallers. I'm extending it into children, which is a very interesting study that I've got some grad students working on now, where we lose some precision. We break it up a little bit, and they've got some animals. And so, did you go as fast as a dog? Did you go as fast as a cheetah? My 7-year-old is the consultant on this project, and she chose the animals, and we tested it on her, and she's giving us some good insights into how 7-year-olds are seeing this. The other thing we're looking at is what's the functional implication of this? So my perception of motion is not within this normal range. What does that mean for me? Is it correlate with symptoms? If I have vestibular symptoms, does it correlate with my overall balance, my gait, things like that? And that's where I think the stuff's going to start to get more relevant and more interesting. I can collect this information in less than 10 minutes. I don't yet know what it's going to mean for functional applications. And that's really the big question. What does it mean for the whole person?
Right. That is so fascinating to me. And, we think, like, at this point in today's world, we have all the technology to measure, all 10 vestibular end organs. And, when we look at the hearing side of it, you alluded to this a little bit, where, you have the vestibular research sort of, or, you have auditory research following a little bit behind visual research, and vestibular research following behind a little bit more of auditory research. And in the auditory world, I mean, we have the most useful tool that clinicians use is an audiogram, and that's a perception of hearing. And so that's really fascinating work that you're doing, looking at the perception of the vestibular system. That's incredible.
But what's really cool is we're not normally conscious of that perception, right? That's the whole invisible disability of a vestibular disorder. It's not something you see. And if you ask someone what the vestibular system was doing at any given moment, they would totally stare at you with like face, and rightfully so. However, if we ask you to be conscious of, and we ask you, you can. And most of the really interesting work in this area is in threshold. What's the smallest difference of motion you can detect in all axes of rotation? And I think that could have really cool implications for diagnostically what's happening in site of lesion. And I went a different direction. I'm more interested in the functional movement, the big movements, because patients don't report, one, they never report that their VOR is not working. That is not a common symptom. But they also don't report small movements causing issues. It's usually larger movements. And that's where you've got oscillopsia or maybe trouble with postural stability. It's big movements. And so we study the perception of big movements. And yeah, it's cool. I think it's got potential to actually be something we can do clinically because it's fast. No, yeah. I had one grant where we ran like 50 conditions, and that only took like 30 minutes. And I would never do that in a patient, but we could do 4 or 5 conditions in probably 5 minutes or less.
It's super fascinating. Yeah, I feel like Danielle and I have talked a lot about perception too. And I feel like this is such a huge area that has so much potential, and there's a million ways to go. Because I could even, while you were explaining, and looking at the falls population and just like how our perception changes as we age, I was like, oh, I bet you could probably have a different pattern for heightened perception type disorders. And then, those that have reduced perception type disorders, like I bet there's patterns for all of those that could be diagnostically really helpful. Because I think one challenge that we are facing a lot of times in the clinic is people are coming with dizziness and our tests may not show anything. So our tests are missing something. They're not sensitive enough to something that the patient is experiencing. So that is super fascinating. And I can definitely see how that's going to be applicable to the patient and recommendations, hopefully.
Yeah, I hope so. I think reflex testing is important, but it's a reflex. It's a brainstem mediated reflex. And it'd be nice to have more tests that tap into central processing. And also, if we're trying to connect our testing with what the patient's reporting, patients are reporting what they're centrally perceiving. But like I said, no one reports on their reflexes. It's the other stuff that the patients are coming to us with. And there's all kinds of things that could be subclinical that don't show up on our tests. And I've got some pilot data on some fallers, and their scaling of the oscillating stimulus is different. And what it is, it's that linearity we saw in the low frequencies continues up or becomes expansive. Whereas we move faster, their perception grew at a greater rate than I would expect, as opposed to our healthy ears where it was definitely nonlinear. So there seems to be a loss of linearity in their systems, which is also, oddly enough, very consistent with what happens in the auditory system, where we lose linearity as we age, and there's perceptual consequences to that.
Yeah. It's almost like they're made up of the same thing material.
It's almost like it's all
yeah. That's interesting. So I know obviously we're still like very early in the research, but we have a lot of clinicians and students that listen to this podcast. So at this point right now with where we are, would you make any specific recommendations to that patient that's complaining of some of these things that are not being picked up by the test that we're doing? Like, do you make any particular recommendations for this population?
Not based on this data. It's too early for clinic, but anytime a patient has a complaint, I try to add a functional measure. And, can we check their gait? Can we do Romberg on film? Can we add something that sort of corroborates those symptoms, even if our reflexes aren't showing what we would expect?
Which I think is a great piece of, advice, because I think a lot of times when we learn to do the vestibular testing, we're very tied to our specific tests and our codes. And I think it's really important, to try to push ourselves to be outside of that concrete area and work in this gray area where we may not have a code, but it's the best thing for the patient, that we really address that complaint, because it's not helpful to the patient or physician.
Exactly. And it speaks to, we know how long these patients are waiting. We know how long, how cumbersome the healthcare system is, or they're bouncing around. And by the time they get to you, they're looking for answers, and, they don't want to hear, everything's normal and okay, now you go somewhere else. So to build in some of these more functional components are just so important for them.
It's a more thorough assessment of the patient as a whole, beyond just their ear.
Yeah. So talk to us. I know you had mentioned you're also doing some research about like vestibular training and teaching. This is something we've talked about a lot on the podcast because we have a lot of students who are always asking us like, how do I train better? How can I be better prepared? So what are kind of your thoughts as you've been diving into a little bit of that research?
Oh, that's new. And it's an interest because I do so much vestibular education. I've got undergrads, AuDs, and PhDs. So I see students at different levels and with different needs. And so I could talk a little about PhD education, but I'm going to go back and talk more about AuD education. And so a project I just started working with Vita on is where we've got these video modules of patients talking about their experiences. And some of it's focused on their physical experience, and some is their mind, and some is, their social experiences with the world. And I have a group of students who are watching the videos with me. And what we're doing right now is just brainstorming. Like, what are we learning from these videos that we didn't know? And what's surprising to you? And the students are coming back saying, I had no idea. This was a humbling experience to watch this 15-minute video, to hear it from the patient's mouth, what this actually felt like, to hear their emotions, not just physically, what are your symptoms? Is it vertigo or is it unsteadiness? Do you have oral fullness or do you have tinnitus? They're hearing the patients really talk about, this is how it impacted my life. And the long-term goal is to basically do a study with students in different programs where half will watch the videos and half won't, and we'll assess cognitive empathy, affective empathy. How are you better knowledgeable about the patient experience, but how comfortable are you now with what patients are experiencing? So you don't come in and go into, for lack of a better word, like tech mode, where I'm going to check off this, check off this, check off this, and forget that this is a person in front of you. This might be a very scared person in front of you whose life is being impacted in ways that we don't understand. So I hope to add that into our regular education piece. And if I can show that it's effective, this would be something we would open up to anyone to add into vestibular education outside of all the things you go through in your syllabus. We have like a whole day where we talk about, okay, who are these patients? What are the patient experiencing, and how can we help address that? And some of it stemmed from a qualitative study I did, and I don't do qualitative. And this was also Daniel's fault that we did that qualitative study because he wanted to, and he was my student. But in the qualitative study, we asked patients a lot about what their experience was like. And so many on the positive side said the audiologist made a huge difference. And what they didn't say, but what I think is true, is because you might have 2 to 3 hours with this person. That might be the longest they spend with any doctoral level profession across their vestibular journey, to have that length of time. So we can use that time to really, really help the patient and be more leaders in a multidisciplinary team about what does the patient need. A lot of times it's not surgical and it's not medical. It's really something else that I think audiologists could work with. And training students to do that outside of go see 100 patients and come back and report to me is difficult to do without some sort of simulation, which I guess is the word I should have been using. So we're looking to create a sort of a simulation for education.
That's incredible.
So fascinating. And I think needed, like, I think in healthcare in general, everybody, like providers, it's known that we get desensitized, like the more patients you see. And I think for that patient, that is the biggest moment of their year or life or whatever. And for you, it's just another patient. So I think being able to keep that perspective, and like we many times become counselors for the patient because they're feeling heard and seen for the first time. And so I think that is super fascinating and very impactful.
Yeah, I mean, it takes the patient. It no longer puts the patient as just numbers. What are the gains, phase, and symmetry values of this rotary chair? How is this actually impacting the patient? So I think that's definitely just so invaluable for students to be learning that and then go out in the field and practice it.
Yeah, I hope so. And that's honestly, it's one of the cool things when you get to, I guess I'm mid-career now, is you start off with this narrow dissertation and you're like, I'm physiology. And then you get to the point where you're tenured and you can I can explore all the things now. And I can look at these types of more SOTL questions or scholarship of teaching and learning types of questions that, maybe 10, 15 years ago, I wouldn't have felt that comfortable going into that. So that is a newer area for me, though. I will say I don't have a lot of experience in this. It's just a direction that my lab's going to go.
I know. Well,
So needed.
well, since we're talking about directions of things, we always ask, every guest on the podcast just to kind of, put it out there. We know that the vestibular community and research, fast evolving, changing all the time. As an expert in this area, where do you see the vestibular field, more specifically the audiology vestibular field, going, 5-10 years from now?
I hope that we have more precise tools to assess vestibular function. So going back to the beginning of this, where I was like, in the visual system, we can do all these things, and in the auditory system, we're a little bit behind. We are way behind with vestibular, and it's not anyone's fault. It's just such a complicated system to assess. And I hope that we can get more precise tools. So I didn't talk about this, but there's a whole other area I do with VEMS where we're looking at physiology in a more detailed manner, where we're looking at things like nonlinearity in the system. We're looking at synchrony of the response, so things beyond amplitude and latency. So I hope there's more tools like that get at more of what's happening in the ear beyond our more gross measures, more perceptual measures. So stuff we've talked about, and also more just in general central testing. We really don't know what's going on. It's like the central vestibular system is this big black box. We know what goes in, and we sort of know what the patient's perceiving, but how is this being processed? When is it not being processed appropriately? I don't want to use the term vestibular processing disorder because that's going to open up a Pandora's box. But there is definitely patients where we see absolutely beautiful peripheral reflexes, and it is not being processed the way we'd expect. They're not feeling this the way one would expect. And I think that would be a good area to see the field go. And that would give us a more comprehensive view of what's happening, like we do with other sensory systems, where we even, whether it's clinical or whether it's research, we can really tap into quite a bit more detail about human physiology and human vestibular physiology relative to other sensory systems is still a big mystery.
And it's so interesting.
Yeah, still one of my favorite projects to this day is that caloric perception study that we did.
That was fun. Yeah. And that really set off all of the psychophysics work, because the study Daniel was talking about, we looked at perception of the caloric stimulus in a very simple way. It was like, did you feel movement or did you not feel movement? And what we found out is it's somewhat related to the size of your caloric response to your Sylvey's eye velocity. However, it was more closely related to your age. And so as you got older, you were more likely to have normal nystagmus, a normal functioning VOR, but you didn't feel it. And then when we went further, we found that those who were older and those who didn't feel it were more likely to fail conditions 5 and 6 on posturography. So there was a postural stability issue that was occurring. After that, it became clear I needed a better way of measuring what it felt like. It can't be, does this caloric feel like anything to you? And so that's really what led to looking for a psychophysics measure that was, that wasn't going to take, 3 or 4 hours per person, and that was doable, and that was, a big stimulus, a functional stimulus. And that's what led to the magnitude estimate series of studies that started when Daniel was here. That was a fun study.
Yeah, definitely.
I think it's a cool time, I think, to be in vestibular world and vestibular audiology world, because I feel like we are moving past the present or absence, and we're looking at the spectrum of functionality. And because I think we've realized that that's not enough for the patient. So everything you're describing, I think, is super fascinating. And I think it's going to mean a lot more to our patients, and also hopefully elevate our field to be a good resource for dizzy patients, because I think that's also still can be a struggle in certain health systems of where an audiologist fits into this process. So I think all of the research you're doing is going to really elevate it. Great. Well, since we have quite a few students who are on this, any advice for students who are in the midst of school, considering a career in vestibular, whether that's research or clinical?
I guess first piece of advice would be to find a mentor. Find someone who's doing what you find interesting or who's done it before. I don't think it's as hard to do, I don't think, as it seems. I feel like we're an open bunch. We're a small group, but we're friendly. And I think everyone's really ready to share knowledge and to anyone who asks. So professional societies can help link students to a mentor, but they could just ask. Just send an email and ask to speak to someone. So I guess first is find someone who's doing this already. And then second would be really seek out experiences. It could be research experience if you have access to that kind of lab or clinical experience, because you don't know it till you know it, and you got to be into it to understand it, I think. Third, I think it's really good to keep an open mind and stay curious, because there's so much we don't know and there's so many directions we can go. And I feel like if students really trust what they're thinking, they might think they're blurting out something random, but it could be like this special nugget of knowledge that no one's ever thought about before, but their perspective changed things, because the vestibular world is wide open for ideas and where could you go and how are you seeing this? And so be open to that and willing to talk about it, and open to learning from your patients. I think patients teach us so much, and so many of my big research questions that take multiple experiments and a long time to get to stemmed from an experience with a patient. Something a patient did, something a patient said, something that just stuck with me over time. From more of a research perspective, if you're interested, in a PhD, you just have to go for it. And I think there's, it's a humbling experience to learn how much you don't know. And I guess half the PhD is figuring out you don't know anything yet. And there's a reason they take so many years. It takes a long time to learn to do research, but it takes a long time to learn how to answer the big questions. And it'd be great if we had more people that wanted to answer the big questions. There's a lot of great clinical research, and that can be done in a shorter time period. And I don't think you need a PhD to do that. We do need more people who have the patience to do the study that takes 5 years to do, that we're not going to collect in the next few months. And that's where we sort of end up pushing the field forward. But it's a slow process. It takes patience. Science just takes time. So I don't even know if that was a number or advice for students, but get experience, get a mentor. Yeah, lots of things. Probably just talking with people, talking with you guys. They can talk to me. Finding someone they can speak with is step one.
Yeah, I definitely agree. We're an open bunch. I feel like everybody that's been on here has been like, I'm willing to help. And I think we all want to see the field push forward. And that is such a great point about we need more PhDs who are willing to do research in vestibular, because I think research is really what moves our field forward. And we all recognize the importance of that, and hopefully can encourage students to take the leap and do that. So thank you for sharing so much. I mean, I'm going to have to think about this conversation for a while, because I feel like I've learned so many things and new thoughts I'm having in my head. But thank you for taking time. I know your time is very precious, so we really appreciate you hanging out with us for a while. And I know everyone will appreciate listening too.
Yeah. Thank you so much, Erin. We just truly appreciate it. You continue to be a role model for me and just so many students out there. And so thanks again for your time.